the next case I will show you, it's actually talking about using the shockwave in the common femoral, and you'll see in this patient, the next patient, um, she's a 65-year-old female. She had a pelvic radiation because of uterus cancer. She had a claudication rudder of 3, and she had an ABL was abnormal. CT showed bilateral common femoral stenosis. So, and she lived in a different state. She was referred to one of the vascular surgeon there, who appropriately proceeded with a gold standard, which is the common femoral endarterectomy. Again, unfortunately, she had a site infection and lymphedema. The site infection required 6 months of IV antibiotics, and of course, lymphedema took years before it became under control. So she came to see me and she said, basically, I want to have the left legs fixed, but I don't want surgery. And I always like to show this is from our colleague in the vascular surgery world talking about, the post-operative complication from a common femoral endarterectomy. It's not as simple a procedure as it is from a complication perspective. I think technically it's a straightforward intervention. But if you look at the data from the SVS, it's showing a 3.4% mortality, 10% return to operating room, wound complications are around 8%. Superficial infection is 5.9, still need antibiotics. So it's not, a risk-free operation. So I think this is where, from this data, where a lot of physician from the IR world, vascular surgery and interventional cardiology has adopted to try to fix the common femoral via percutaneous option before sending them for surgery if they're appropriate or they're high risk. So this is a lady clearly a high risk. You see, a very calcified subtotal occluded common femoral artery. Again, I always teach the fellows the most important artery in the leg is the profunda. You can see here the profunda is also subtotal occluded. So in all the common femoral artery, we use IVUS. IVUS guided. We use an 014 IVUS will reach. And what we did in this lady, we put a 119 sheet, landed in external iliac. We crossed with 2 014 wires, one to the profunda and one to the SFA. We used a 6.5 by 60 M5 plus IVL shockwave. Start with the profunda, then to the common femoral to the SFA, and we finish with a drug coating balloon. I think that was a Ranger, it is 7 by 80, and this is your final result. Again, this patient went home the same day. One access sheet, one access saw, which is the radial. No distal embolization because of the safety profile of the IVL. The profunda is completely open, and she doesn't have to worry about a site infection. Just showing you that those are possible options from the radial. Again, all that was
Yeah.
done through a 6 French sheet.
Yeah. It's fantastic. Beautiful result too.